You know we're live.
So it's like it's
Thank you.
either like Anchorman. It's a mixture of Anchorman and a mixture of Newsroom.
I don't know.
That's how I see it.
Just so that you
Twig,
know, we
twig.
are already live. So, hello everybody. Welcome back to This Week in Global Health. This Week in Global Health is a live, as you can tell, weekly global health news roundup. We're broadcasting from all over the world, and we've got a live audience. Today is Wednesday, the 19th of November, 2014. And in the month of November, we've been talking about access to medicines. And in tonight's episode, we're going to focus particularly on the issue of IP, or intellectual property. Before we carry on, I'm going to ask the panel members to introduce themselves. Starting with myself, my name is Greg Martin. I'm going to talk a little bit later about the medicines patent pool. Next up, Jessica. Jessica, talk to us. Who are you? What are you going to talk about tonight?
Hey everyone, I'm Jessica Tapp. I'm coming to you from the Washington D.C. metro area, where it is 2 p.m. right now. And today I'm going to tell you, that it's World Toilet Day and why you should care about it. And I also will be telling you and explaining what the access gap is in regard to and how intellectual property issues can resolve this.
Okay, thanks very much, Jessica. Brian, talk to us. Brian from Johns Hopkins.
Yes, hey, Brian Simpson from Johns Hopkins for Global Health Now, and I'm reporting to you live from New Orleans, Louisiana, from the American Public Health Association meeting. And I'll give you two highlights from today.
Brilliant. Thanks, Brian. Next up, Chris. Chris, talk to us.
Hi everybody, I'm Chris Ronson. I'm coming to you from San Francisco today. It is 11 a.m. and it is pouring rain, as Greg will be thrilled to know. Today I'm going to talk to you about patents in regards to intellectual property, and we're going to review a little bit of the TRIPS, or trade-related aspects of intellectual property rights.
Thanks very much, Chris. Now, we're very excited. We've got a guest from MSF, and we, on the show, we quite often use the term, we love MSF, because we just love everything they do. We've given them a cheer, a clap. We've got Judith from MSF. Judith, can you tell us about yourself and what are you going to talk about today?
Good afternoon. I'm Judith Reus. I am calling from New York, where it's pretty chilly. I work for Doctors Without Borders at the Access Campaign. I'm the U.S. manager and legal policy advisor of the Access Campaign at Doctors Without Borders. I'm going to talk about what Greg asked me to talk about. That is some of the recent challenges that MSF is seeing, increasingly challenges for access to medicines and vaccines in countries considered middle-income economies, apart from the challenges on accessing medical technologies already in low-income economies, and also on a concept a little bit nerdy, the concept of TRIPS Plus and some of the provisions that we've seen in some trade agreements that will make the situation worse for access to medicines.
Okay, thanks very much, Judith. And another guest that we have on is Anna. Anna from the UAEM. Anna, could you tell us what UAEM stands for and what are you going to talk about tonight?
I most certainly can. First of all, I'm reporting from London School of Hygiene and Tropical Medicine. Right now it's in London, so it's 7 o'clock. It's not raining, but it should be because
you're
it's
in
London.
The canteen, I understand.
I'm in the canteen, as luxury as it sounds. So I'm representing UAM, Universities Allied for Essential Medicine. We're a student organization in an international NGO working on access to essential medicine, and I'm later going to talk about the work we've been doing in WHO or in relation to WHO on how to de-link the cost of research and development from the price of products, so the price of medicine.
Excellent. Well, I am looking forward to that. Right, just a couple of announcements. Of course, we've got a live audience. If you want to send in questions or comments to the panel, we'll answer them later on in the show. You can tweet them to us at #Twig, TWIGH. You can send them to us via our webpage, www.twig.org, and we will get to questions and answers later. Also, at the webpage, you can sign up to the show notes. It's a newsletter that we send out, and it's got all the links and URLs, and everything that we mention in the show gets sent out as a newsletter. So sign up to that. One more thing, of course, is that we've got our podcast out. So if you like listening to podcasts, you can get the audio version of this show weekly as a podcast. And of course, we've got a blog, and we're looking for people to contribute to the blog. So if you're wanting to get some of your ideas out there and some exposure, please go to our webpage. You can submit a blog via the webpage. Right, let's jump right in. Jessica, talk to us. Today is World Toilet Day. Jessica, tell us about World Toilet Day.
Yes, it is. And okay, a lot of our viewers may be thinking, World Toilet Day. I didn't even realize that's a thing, but it is, guys. So, and you may be thinking, why would you have a World Toilet Day? Besides the fact that, if you think about it, if you don't have a toilet, it goes beyond just being uncomfortable. Having sanitation is important because if you don't have access to sanitation, there's a variety of health problems that can happen. I mean, it makes diseases easier to spread. It can affect drinking water, and it also contributes to undernourishment and poverty. And what you may not know is that 2.5 billion people globally don't have access to improved sanitation facilities. This means that actually more people have access to mobile phones than to toilets.
Wow.
And a child dies every 20 seconds because of poor sanitation. So it's really a big deal.
2.5 billion people.
Yeah.
That is like a third of the world population.
Yeah, it's a lot of people, yeah. And more
huge.
people have phones, mobile phones. So, but just having a toilet isn't enough. And there was a recent study in Lancet Global Health that found that in a randomized control trial of latrine promotion and construction to reduce diarrhea, they've also found that it's not just increasing coverage for latrines and toilets, you also have to increase the uptake of them. So that's another important thing. It's not just about giving and we're going to talk later about it, just medicines. It's like making sure that people have access to it and use it the right way. So that's an important thing to point out. And I wanted to share with everyone on kind of on a lighter note, because anyone that works in this kind of field of toilets and water and sanitation and health, otherwise WASH, people have to have a good sense of humor about it, because you're talking about toilets and you're talking about poop a lot of times. So I want to share a photo that's one of my favorites. This is from DFD, and I think it's I forget what it's called, but it basically, if you can't see it, it says "I love toilets," and it's like little Lego people. You've got Jesus, Elvis, a Native American, someone in a wheelchair, kids. So next time you guys think about it, think about your toilet, just think about how many people don't have it and are very uncomfortable with it.
2.5 billion people.
Yep.
Like a third of the planet. Wow. Okay, excellent. World Toilet Day, don't forget it, very important. We're going to move right on. Brian is going to give us a news update. Over to you, Brian.
Hey, thanks. Thanks, Greg. So I'm here in New Orleans for the American Public Health Association conference, and that's 13,000 people from the U.S. and around the world attend this. And so, to say two things about it is really absurd because it's this massive, massive conference. But I'm going to try. I'm going to try.
Summarize the entire conference for us.
That's right. I'm just going to give you two highlights. The first was on Monday afternoon. 6 surgeons general of the United States, 5 former and 1 the current acting surgeon general, had a kind of a powwow on stage, and there was probably at least 1,000 people there watching, and it was electric. I mean, I have to say, it was really, really fantastic. And we have lost in the U.S. We have lost so much. The Surgeon General's office has lost so much power because of political wrangling. I won't go into. But having these people together and seeing their dominant personalities, it was so exciting, and it really shows you how important the bully pulpit is for the Surgeon's General office. They had a couple great quotes. Antonia Novella, who's a former Surgeon General, said, "You have to be a Surgeon General with an agenda. You've got to come in with an agenda in order to make things happen." Joycelyn Elders said, "America needs to transform its sick care system into a health care system." And they made terrific points, and they're terrific advocates for public health, and they were really preaching to the choir here. I mean, this is like one of the, an audience where somebody mentioned a breastfeeding campaign from the 1990s, and the crowd erupted into applause. So it was just terrific.
Well, we got to get those guys on the show. I mean, I'm going to track them down. That's our mission.
Surgeon General? Is that what we're going to do?
Why not? Yeah, let's get them.
Yeah, absolutely.
If you're a Surgeon General or an ex-Surgeon General and you're watching the show, we want you on the show. There.
Come on down.
Exactly. It's on YouTube.
And so I want to tell you the other highlight. This was fantastic. Our associate editor at Global Health Now, Dana Kiersman-Myers, attended a session on post-Katrina disaster capitalism. So Hurricane Katrina really destroyed the city of New Orleans in 2005. Afterwards, the city and the state in its infinite wisdom decided not to refurbish Charity Hospital, but to sort of leverage the damage in order to build a new hospital. And basically what they did was they took away a great facility, they reduced the size of the next facility, they placed it in a poor neighborhood. So the message that the advocates speaking yesterday said was, it was really driving out the poor and bringing in the rich. And so they call this concept disaster capitalism, and it's a genuine concern for post-disaster situations and what happens afterwards. So it was very, very powerful, and you can see just talking to the people in the audience were crying. Katrina is still very, very real, still very, very much with the city of New Orleans, unfortunately.
Wow. Okay. Very interesting. Thanks very much, Brian. And as always, thanks very much for being on the show. And as always, we love the Global Health Now newsletter. If you don't subscribe to it, we recommend that you do. Full of great information. It's every weekday. They only take weekends off. These guys work hard.
That's right.
Great news, and it comes as an email, and we love it. Right.
Great.
Jessica.
Thanks so much for letting me talk from New Orleans. I'm going to sign off now.
Thanks for coming on, Brian. Okay, Jessica, over to you. Talk to us about access gaps.
Right. Okay. So last week, so you guys know that this month we've been talking about access to essential medicines, and last week we covered the research gap, particularly pointing out how disparity in research for neglected diseases that need new medicines isn't, pointing out where it is. But there's also an access gap. Particularly, there are medicines that already exist, but people can't access them. Now, this is really important because this includes life-saving medicines that are on WHO's essential medicines list. In fact, it's estimated that 1/3 of the developing world population are unable to receive or purchase essential medicines on a regular basis. And this results in so much unnecessary morbidity and mortality. And there are several reasons for this access gap, particularly high prices of drugs, lack of infrastructure, which includes, storage for drugs, transportation to the clinic, human capital in terms of like medical staff, and sometimes there's a lack of political will. Now, if you think about it, addressing all these issues is pretty major, right? However, since we're talking about intellectual property, this is something that if you work with this the right way, it can help bring down the prices of drugs and then reduce the access gap to the medicines.
Right, very interesting. And of course, we're going to be talking about that today, intellectual property, and how what we can do and what the sort of TRIPS agreement is and what the provisions and exceptions that can be made within the TRIPS agreement to try and improve access to medicines. So that's a great introduction. It's a great segue from last week's show. Last week, if you haven't watched last week's show, it's on YouTube. It's all about the R&D gaps, right? So what drugs don't exist, what do we need to be developed to improve access. Now we're working with, okay, let's assume those drugs do exist. How do we get those drugs into the hands of the people that need them? Okay, thanks very much. Now we're going to go over to Chris. Chris is going to give us a little bit of an overview of patents, the World Trade Organization, and the TRIPS agreement. Chris, hit it.
Thank you, Greg. As both Greg and Jessica said, we did touch on this a little bit last week, so this is our continuation of access to medicines. To give you a brief overview of patents, patents basically give the owners or the producers exclusive rights for the production, use, or sale of a product. And this is for new, useful, or non-obvious technology, and this includes medications as well. It allows the owners to charge higher prices than they could get if everyone was allowed to sell, so it creates a monopoly. And patents only apply within a specific country, not internationally. Each patent must be registered within each country it's intended for use in. Now, the member countries of the WTO, the World Trade Organization, must respect multilateral trade agreements when they want to go ahead and export drugs to other countries. One of the primary ones, or the agreement governing patent law, is TRIPS. As we mentioned, it stands for Trade-Related Aspects of Intellectual Property Rights. TRIPS has been around for a while. It sort of creates a minimum of 20 years patent protection for all medicines and the other technology that has been patented. It allows countries to override patents in time of national emergency. One caveat is it's not international emergencies, just national emergencies. And they can do this via something called a compulsory license. The compulsory license allows the government to grant someone else the right to also manufacture, sell, or use patented technologies. They basically give somebody else the right to create a product without having to run it through the original producer. And this takes away the monopoly, creates competition in the market, and helps drive the price down for people who need these essential medicines the most. Unfortunately, though, compulsory licenses tend to be useful in countries that have domestic pharmacology or pharmaceutical manufacturing situations, which tend to be highly developed countries. This leaves poor countries left a little bit in the lurch because they still have to source their medications from these wealthier countries.
Okay, so Chris, I have a little bit of a loaded question because I know how you're going to answer it. But with respect to compulsory licensing, what if you've got a country that says, look, we'd like to issue a compulsory license, right? Because we think there's an emergency in our country. We want to issue a compulsory license to allow for the generic manufacture of a particular drug in our country, but that country doesn't have the manufacturing capabilities. Is there a way around this, and what is it?
Yes, fortunately, because a lot of emphasis in the last couple of years has been put on making sure that the pharmaceutical companies and that health is actually driven by need and demand, and providing access to countries that don't have the settings or the resources to create their own medicines and things along those lines. In 2001, they passed the Doha Declaration. And so anyone who's interested in hearing more about that, the most specific, most important part of the Doha Declaration is Section 6. I'm just going to read directly from it. And it basically says the solution is essentially a waiver of the export restriction, which allows the total amount of production under a compulsory license to be exported. So it basically kind of cuts away all of the restrictions and the barriers so that in dire situations you can export these medications to the countries that need them most and put things sort of in perspective, or prioritize the global health situation as it is.
Yeah, okay, and just to give a little bit of clarity, basically that was in response to the fact that the original kind of thinking around the compulsory license was that you could issue a compulsory license in the event of a medical emergency or a health emergency in your country, but it was exclusively for domestic use. In other words, you couldn't sell it outside of the country. And now they're saying, look, if country A has got a compulsory license and country B has, but country B has issued a compulsory license but doesn't have the manufacturing capability, country A can sell to country B. They can't. My understanding is they can't sell to anybody. Both countries need to have issued a compulsory license or applied to the WTO for permission to issue compulsory licenses. But it certainly circumvents the problem. So I think that's fantastic. Another small bit of just a little piece of clarification with respect to the WTO. They've got these multilateral trade agreements. Members of the WTO aren't automatically signed up to the multilateral trade agreements like TRIPS, but the countries sign up to these agreements and then they ratify the agreements in their national legislature and then they become legally binding within their country. All right,
and it's sort of integrated into their own infrastructure and their own laws. But there's like a baseline of things that they have to integrate into their own independent country-specific regulations and rules on patents and intellectual property.
Right. Okay. Very good. Thanks very much, Chris. That was a great little summary. Incidentally, I mean, a little factoid. I think it was at the time that the Doha Declaration was being talked about. So it was, I think, when was it? 2001.
2001, I believe.
2001. Now, if I understand correctly, was that not the same time that there was the anthrax scare in the U.S.?
I think that was one of the things that really compelled it forward. It's funny how we had that in 2001, and then now this is all coming again sort of center stage after the Ebola scare. It's once you've got something that has the capacity to spread, everyone's looking for an alternative to. Because
it was during the Doha Declaration, you had this anthrax scare in the States, and then the U.S. suddenly realized that they might not have enough ciprofloxacin. So ciprofloxacin is the drug that you use to, either prophylactically or to treat anthrax. And so they said, the U.S. said, and they're usually the country that are kind of opposed to compulsory licenses being issued because a lot of the manufacturers are U.S. manufacturers. But they were the ones that said, look, we're gonna issue a compulsory license for the manufacture of ciprofloxacin by domestic generics companies. And of course, my interpretation is just the threat of a compulsory license being issued in the United States made the pharma companies step up and actually make these things available, make ciprofloxacin available on a large scale at a cheap price in the United States. But it was very interesting historically when it was that happened.
They definitely responded by almost volunteering to do it so that it didn't circumvent the laws that they had in place. So there was a big response to actually lowering the prices of the anthrax prophylaxis.
Okay, and of course we're going to have links in the show notes for more details because we can't get into everything in this show, but of course we'll have links in the show notes. If you want to read more, get the show notes. You can subscribe to them at our webpage. I'm going to talk a little bit about the medicines patent pool, right? So while we're talking about intellectual property, one of the problems that we're faced with, and I'll tell you, let me firstly tell you what the medicines patent pool is. Medicines patent pool has been designed to try and facilitate the licensing of antiretrovirals to treat, HIV in all over the world. And the way it works is this. Ordinarily, manufacturer A and manufacturer B and manufacturer C have patents for drug A, B, and C, and they license these things out in country 1, 2, and 3 to be manufactured. Sometimes they license it out to themselves, sometimes to generics companies. Now, that they need to do that in every single country. If they want to give a license to a generic manufacturer in country 1, they have to have a separate licensing agreement with the generics manufacturer in that country, and again in country 2, and again in country 3, and then manufacturer B has to do the same thing. So you have the same process getting duplicated again and again and again and again. What the Medicines Patent Pool did is they said, look, all of you innovative companies can issue a license to the Medicines Patent Pool, who will themselves issue sub-licensing agreements with the generic manufacturers in all of these developing and low-income countries, right? So it really just kind of made this whole process work much more efficiently and much faster. Now, where that becomes important is, for example, when you're wanting to manufacture a fixed-dose combination pill, which is, of course, the case in HIV, right? We've got these single pill that's got 3 drugs in it. It's much easier for people to take. It increases compliance. They're fantastic things. But very often, the active pharmaceutical ingredients in a fixed dose combination pill are patented by different companies, right? And it becomes very complicated getting all these different companies to issue licenses to a number of different generic manufacturers across a number of different countries. And the Medicines Patent Pool really just makes this whole process work. And they're absolutely fantastic. They're funded by Unitaid. They started in about 2010, so they're relatively young. I know them quite well and love them to bits. So if anyone from the Medicines Patent Pool is watching this, big shout out. We love you guys. Well done. Good work. Keep going. Okay, enough about that. Judith from MSF. Judith, I wonder if you could quickly tell us about the MSF Access campaign, because a lot of people, when they think of MSF or Doctors Without Borders, they imagine some doctor with a parachuting into some conflict area with a stethoscope and a syringe, saving the day. And of course, MSF do a lot more than that. Could you tell us about the MSF Access campaign?
Sure. Thank you for the invitation, first of all. So the MSF Access campaign is a team within MSF that was created in 1999 when MSF won the Nobel Peace Prize in 1999. With the funding and that recognition, decided to create a team within the organization, a small team within the organization that works on, coming from the frustration of our doctors and our teams in the field, was asked to work on 2 main issues. The issues of access to medicines and medical technologies, medicines being broadly, meaning that medicines, drugs, vaccines, diagnostics, the fact that many of the tools that we need, as the previous speaker have said, exist for you and for me, because we live in the United States or we live in Europe, but they're not affordable, they're not accessible to our medical operations in developing countries because they're too expensive. So bringing the price down of medicines and diagnostics and vaccines was one of the main mandates that the Access campaign was asked to work on. The second mandate was also coming from the frustration of our medical teams trying to basically do our work in our medical operations and being not having the right tools, not having the vaccines, the drugs, or the diagnostics, because they don't exist, because there's been no R&D efforts to invent them, because mostly some of the diseases that we treat and that we try to prevent mostly affect poor patients living in developing countries that do not represent a lucrative market for some of the pharmaceutical companies and some of the research and development investors. So trying to push the research and development agenda, so new medicines, vaccines, and diagnostics will be coming into our hands and into the hands of the doctors that try to save lives every day in our operations, and also adapting this medicine to resource-poor settings. So it's not enough to have a vaccine. It's not enough to have a drug. The vaccine and the drug have to be able to be used in resource-poor settings, especially where we work. So, for example, we're doing quite a lot of work on increasing the thermostability of vaccines to reduce the use of, basically trying to use vaccines if we can, if the data supports it outside the cold chain, specifically trying to reach children in very rural and remote areas. It's a big challenge for us to have to rely on heavy cold chain equipment. So trying to adapt the medical tools, the diagnostics, the vaccines, to the patient's needs and to the operations in the countries where we work. Right now, we're working in around 80 countries, most of them, as you can imagine, developing countries, although a variety of contexts, but most of them quite difficult situations.
Okay, Judith, I wonder, one of the things that when we talk about intellectual property, we often talk about TRIPS, and if you read around this, you often see the term TRIPS Plus pops up. And a lot of people see TRIPS Plus, and it sounds like, oh, that must be a good thing, right? It's got a plus at the end of it. You know, that's almost like a tick. That must be a good thing. Could you tell us just briefly, what is TRIPS Plus? What does it mean? How does it impact on access to medicines?
That's a good point. We should not say TRIPS Plus seems positive, but it's not positive at all. So, as I will explain by a previous speaker, in 1995, all the WTO members agree to a level of intellectual property protection, a global level of intellectual property protection for a variety of technologies, including medicines. That includes an obligation to grant patents for medicines now for 20 years, since 1995. What we've seen since then, and is escalating, and is an the European Union member states through a variety of tools, including trade agreements like the Trans-Pacific Partnership Agreement that is currently being negotiated between the US and 11 other countries in the Asia-Pacific region. What we see is demands on the side of the US and and the European Union in some of its trade agreements with developing countries and developed countries is to increase this level of protection by extending patent monopolies beyond 20 years and creating additional monopolies not based on patents. For example, data exclusivity for new biologics is one of the biggest concerns we have right now with this Trans-Pacific Partnership Agreement that is currently being negotiated. So it has three goals. TRIPS Plus provisions means provisions to go beyond what was agreed in 1995 in the TRIPS agreement, and the goals are mostly three terms. One is extend patent monopolies and extend them and strengthen them. So ensure laws at the national level will be modified so pharmaceutical companies get more patents for longer periods of time, where of course is negative from a public health perspective because it means less access to medicines. Create new monopolies that are not based on patents, like, for example, the exclusivity for biologics that I just briefly mentioned. And third, take away flexibilities that countries have, like the example of the compulsory license that you just mentioned. Take away tools and policy tools that countries have the right to use according to international law and national law, take them away and kind of lock countries into a very difficult position that will, in fact, and it's in fact already increasing substantively the cost of medicines and many of the countries where we work. Okay. So we are against TRIPS Plus, just to be clear. We don't like them.
I think most people that are working in the global public health space and that are involved with access to medicines are also kind of opposed to TRIPS Plus, and we can certainly see the negative impact on public health that kind of thinking that it translates into. I'm going to ask Anna. Anna, thanks for joining us. Anna, could you talk to us about this idea of delinking cost and price? And I'm going to listen carefully because I think what you're about to say is extraordinarily interesting. Anna, over to you.
Yeah, so we touched upon the issues of the R&D gap and so on. I'm going to focus more on proposed solutions. So the WHO for the last 10 years has been focused or have created several working groups trying to solve this whole issue of how to de-link the cost of research and development from the price of medicine, as the current system of monopoly, as Chris so well explained, it drives incentive of earning money from the monopoly you gain from a patent, which in real life really encourages innovation for diseases affecting populations that can afford to pay for the drugs. So the WHO have been working on trying to solve this, and they set up a working group in 2010, and they published a report in 2012. It's called the Consultative Expert Working Group on Financing and Coordination of Research and Development to Meet the Needs of Developing Countries. So a very long title, and it's also a very long report, but they have set out a set of recommendations. Among them are, as you mentioned, Greg, the medicine patent pool. So they called for a lot of organizations to feed into this process in 2010. UAM was one of the organizations. We proposed to have equitable access licensing as a mechanism to promote research and development and access to these medicines developed. But they created a framework, or they recommended a framework with different mechanisms to promote research and development, and also proposed that they needed that there was a global need for funding for development of these drugs, which would be financed through taxations of the member states of WHO. And they proposed that this framework should drive the entire process of research and development. So beforehand or currently, we're seeing that research and development, the first stages are often publicly funded, but the expert group recommended that the entire process has to be funded through taxation, so that it's not driven by the incentive of a private company earning money, but the incentive of meeting the needs of people affected by disease.
Okay, that's very interesting. Anna, this idea, I mean, needless to say that there's opposition to it. Can you just talk us through a little bit about the resistance to this idea? Where's that coming from, and in a sense, what is your response to it?
So in general, the entire global health society and also the pharmaceutical industry and member states agree that there is a market failure. The pharmaceutical industry is very openly saying that we don't have an interest in investing in these diseases because the return of investment is so low compared to diseases affecting people that can afford the treatment. So everybody acknowledges the issue, but where it becomes really complicated to actually implement this framework is because the expert working group recommended that it should be a convention, so it would be legally binding, saying that if member states don't feed into this pool funding for research and development, spending 0.01% of their GDP on research and development for diseases affecting developing countries, then there would be some kind of punishment. They don't say exactly which kind of punishment, but they are encouraging the framework to be implemented under a convention under the opinions of WHO. And of course, a lot of member state countries are against being legally binded to invest in research and development for diseases maybe not even affecting their countries.
Right. That's interesting. Okay, super interesting. Thanks very much, Anna. Now, we're going to end the show there. If you're watching this on YouTube, this is, things are about to end. If you're watching this live, don't go away, because we're going to have a little session of questions and answers and comments and some discussion amongst the panel. That's coming up. Next week's show is going to be about who is doing what in the area of access to medicines. So we're going to go through all the stakeholders, all the organizations, and why that's important, because what we're going to supplement that with is, if you're interested in working in this area of access to medicines, next week's show is all about where you can get a job, right? So we're going to talk about employment, job opportunities, who's hiring, who's firing, who's doing what. Very exciting stuff. So tune in next week, same time, same place. Access to medicines, who's doing what, where you can get a job. Enough from me. For all of you watching this on YouTube, come back next week. Don't ever change. Don't do drugs. Always do your best. And we'll speak to you soon.